Away we go.
Hello.
Oh God.
Edit that out.
Like a Fraggle the Rocco.
So welcome to the Extreme Medicine podcast. We are here at Everest ER at 5,345 meters. So I'm Yash. I am emergency medicine mountaineer, HEMS doctor, and a mountain doctor. I'm with Jan, who is...
I'm Jan Trojanowski, an emergency physician as well at critical care, and with a subspecialty in pre-hospital retrieval and transport. And living in Canada now, hanging out with Yash at Everest Base Camp.
And we've got the absolute privilege to chat to the Everest ER docs here, who are Susie Stokes, who is an ED trainee from Oxford in the UK, Pranab Karela, who is a mountain and travel medicine doctor from Nepal, and Sanjeev Bandari, who's also a mountain and travel medicine doctor from Nepal. So, first of all, just a bit about your backgrounds and what brought you to Everest ER. Take from me, Susie.
Okay. Hi, I'm Susie. I'm a registrar in emergency medicine in Oxford. I've always been interested in mountaineering, climbing and the outdoors, and I had the privilege of working at Everest HRA clinic back in 2010 in the fall season. And as soon as I knew that Everest ER existed, I wanted to come and work here. So here I am in spring 2014. It's been extremely challenging already. We've seen about 130 patients so far, and you'll be hearing more about that later. Yeah, that's pretty much why I'm here.
And Pranab?
Hello, my name is Pranab Koirala. I am a Nepalese doctor, and I had worked in Everest ER last season, full season also, and this is my second season. And normally I work at a travel medicine clinic in Kathmandu. I did my basic MBBS degree from Nepal in Kathmandu, and after that I went on to do diploma in mountain medicine and mountain rescue medicine from Italy. I did diploma I also ran a diploma in mountain medicine in Nepal in 2012. So here I am, very happy to work with SRA again. This has been one of many times I've worked with Himalayan Rescue Association, and we have a very good team. Glad to be here.
Sanjeev?
I'm Sanjeev Bandari. I did my MBBS from Trojanowski University Teaching Hospital, and I'm currently working as an intern in the same hospital. And I recently did my diploma in mountain medicine, like the practical part, before I came here, but I'm yet to finish that course yet. And since I knew that Nepalese doctors can volunteer in the Everest ER, I was interested to be here.
Excellent. So could I just confirm that all of you are here for the whole season, is that correct?
No, I'm not here for the whole season. I was called in to replace another doctor who was not, who could not complete the season because of his personal health reasons. So I'll be here. I'll be replaced by another doctor who will be here after around 10 days.
And all you guys volunteer to be here?
Yes, this is all voluntary work.
And what is your season?
Sorry, I didn't get it.
How long is your season?
The total Everest ER season? It is usually the beginning of the season. We start the clinic from usually in the first week of April, and then it goes on to the last week of May, depending on when the summit bid is, the weather window. And for this, we have to start trekking at least 10 days before the start of the camp, and then we also have to take time. Maybe May, June, we reach our homes in maybe first week of June.
Sure. Susie, could you tell us a bit about the history of Everest ER?
Yeah, so this is the 12th season, is that correct?
Yes.
I think this is the 12th season that Everest ER has run. It was set up in 2003 by Luan Freer, who recognised that whilst the HRAs run the clinics in Manang in the Annapurna circuit and Farishay just down the valley, that there was a lot of need for healthcare up here. Obviously, we know it's quite a dangerous environment to be in. There's hundreds of people here at any one time. That includes trekkers, climbers, Sherpa staff, base camp staff, administration staff. So there was a definite need for medical care that was recognised, and so Everest ER was born. So this is the only of the HRA's temporary clinics. So when the season finishes, all of these structures disappear, everything is dismantled and kept for next year.
All right. Sounds like a very interesting job. How does your normal day go? So from start to finish, how does it normally run for you guys? It sounds like if all three of you here, you're running 24/7. How's it normally structured?
Okay, so as you said, it's a 24/7 job for the whole time we are here, and then but normally the day would be like we start of the day. The clinic opens from 9 in the morning to till 5 in the evening, and then we wake up around 7 or 8, have our breakfast here in this tent, and then go on to our white tent to have the patients who are usually not trekkers, but the people living here, the climbers on the surface.
We'll see people at any time, so though we say we're open 9 till 5, people don't actually just come at those times. They come first thing in the morning even. Sometimes the sicker ones will come late at night or even in the night if they're really poorly. So we'll see them at any point, which is why it's so important to have a number of doctors here, because if you have a patient that you have to care for overnight and you're staying up with, you then need to rest the next day.
Okay. So do you each take a turn being the lead physician for the day, or is it a shared responsibility?
Shared pretty much.
It is a shared responsibility, but from the hospital world, I think Susie is the most experienced of us three, and so we for critical patients, and then we generally discuss, but it's we listen to her advice more often.
And so, what kinds of patients do you see? Like, what's your common presentations most typically that you see during the day or at night?
Yeah, it ranges from simple like sore throat and difficulty swallowing anything from pharyngitis to severe cases like passing out somewhere from unknown reason, or severe AMS, or high altitude pulmonary edema, or any. We haven't faced it yet, but it also goes to severe traumas.
And so, how much trauma do you typically get here? Do you think on a percentage basis, maybe?
You can probably best answer that from last season.
Well, it is very difficult to actually put it in percentage because what blisters and then stuff like that count as trauma, right? So I'd say around roughly around 30%, 40% of all those, trauma, including blisters and then minimal rock fall or ice fall.
So you get the lacerations and broken bones, those sorts of things.
And then cramping injuries, and then ISX injuries.
Okay. What's been your most interesting diagnosis so far? Like, wow, I didn't think I would see that up here.
We had quite a challenging case about 10 days ago of a patient who was found collapsed. So the differential for a collapsed patient is wide no matter where you are. But up here, our diagnostic limitations mean that any patient that collapses with unknown cause was going to be evacuated for further investigation. So that was a challenge because he was unconscious for the first part of the rescue and then confused for the second part. So it was difficult to obtain any kind of history, particularly when there were no witnesses. So that was definitely, and all the people you'd normally call on in the hospital, so you'd arrange your CT scan, you'd call for neurology or neurosurgery for consultations, aren't available here. It's just whatever you have, which is limited.
Yeah. So speaking of that, what kind of diagnostic equipment do you have here that's available to you?
We have very minimal facilities here. Well, it depends on the season actually. Sometimes some seasons some things are not running very well. We have ECG in our base camp clinic. We have a simple ultrasound machine here. We can do urine dipstick tests and other simple tests. We have other common things like saturation probes or monitors, and then ophthalmoscopes and otoscopes. Yes, I think that's it. Right?
Yeah. We don't have any facilities to test any bloods, do any blood gases or anything like that, which would be particularly interesting up here. But ultimately, if someone's unwell, it's not going to change your decision about their disposition.
Okay. And when it comes to disposition, and talking about evacuation, is there a set criteria that you have where you must meet these certain things, or is it just becomes, is this too much to handle, we must move this patient out?
Yeah, I think for the majority of cases, it's fairly clear from the outset of the case what's going to happen to them. The people with HACE and HAPE, severe AMS, severe trauma, clearly aren't going to manage up here. They need to go down to get better, but they also need to go down for the treatment, any of the treatment they can receive. So those ones tend to be quite clear. There's a number of cases that we monitor over a period of time, so we ask people to come back the next day. For example, infections, because you can start a course with something like antibiotics, but that's no guarantee it's going to get better. So then there's some people who we're just not sure are going to manage, particularly people who are here to climb. And even something like dehydration can leave them completely incapacitated and unable to carry on their trip. So we try and involve the patient in the decision because it's a big thing. It's the end of your trip if you have to go down, so it's a big decision to make. So we try and involve them in the decision making, although most of them you find have already come to that conclusion themselves.
And because Jan and both are working critical care, we're just a bit interested about how much critical care stuff you guys can do up here. So you obviously have oxygen.
Yes.
Do you have a gamma bag up here?
Yes.
A ventilator?
No.
But you can hand bag someone.
Correct.
And just to come back to that, just for our viewers, do you want to describe what a gamma bag is and when you would use it?
Yep.
Gamma bag it's a kind of airtight bag where you can feed a person, and you can increase the barometric pressure inside the bag by pumping it, which simulates that you are in the lower altitude than you are. So it's kind of.
So it's a temporary measure to, if you simulate the barometric pressure so they get better, you can get them down. Okay, excellent. And on the evac situation again, on an average season, how many patients would you evacuate roughly?
It depends. You mean just like helicopter evacuation? Or
Yeah, and so what modalities do you have? You have helicopter, do you ever carry anyone out?
We have helicopter evacuation. We sometimes people get carried down if there is no helicopter, and then there are people who can walk down sometimes, especially with frostbitten hands or something like that. And then yes, I think these are by far the mostly used. Sometimes horses especially from Gorkset. Well, if it comes to that, then maybe yaks.
The yak ambulance.
Yeah.
Yes.
Or the flashing light as well.
Yeah, we always have to think about safety in terms of evacuation because helicopters can also have their own dangers, as you well know. They only fly in good weather. It's obviously the higher they go altitude-wise, the thinner the air is, the more difficult flying is. And there's very limited landing places around here as well. And then it also depends on the patient having evacuation insurance. So if there's a Nepali patient, if they're with a big expedition company, then actually for the last couple of seasons they do tend to insure their porters, climbing Sherpas, kitchen staff as well. If they're critically ill, they will also be helicopter evacuated. But traditionally, and you do still see it sometimes of those who are working freelance, they don't have the benefit of a helicopter evacuation. So even if they're critically ill, they're still being carried on the backs of their friends.
And, I mean, we were quite surprised at some of the conditions the helos here fly with.
Yeah.
Pilot seems to be quite amazing. But how would you package a patient for a helo evac? Is there anything you consider in particular?
It's difficult because there's only one helicopter company that has helicopters sufficient to take stretchers. So the others, if you have a stretcher patient, you have to roll them off the stretcher onto their back and bend their legs. So in terms of physical packaging, it's actually quite difficult. Most of the trauma patients we've had, we tried to immobilise, but again, it was improvised. And then probably another important consideration is a medical escort. So there's no medical retrieval service here, so there's no one will come up to take them down. So if we think someone's critically ill and needs a medical escort, then one of us might have to go down and try and hitch a ride back up afterwards.
So you've got no way to get back up, really.
The helicopter companies are very understanding and very generous, and they will, if they're coming up on a cargo flight, usually let one of us hop on and come back up.
And in terms of your triage tertiary destination, is there one particular hospital you would use to send patients to?
No, but often the hospital that we send to depends on the severity of the illness or of the diagnosis maybe. So we do not usually send a patient to one particular hospital.
And how would you make that referral? Would you use radio? Would you phone them?
We usually, the phone networks are not very good all the time here. So usually, if the network is available, we try to phone them, and then otherwise, they just have to go with the refrigerator.
Any idea of how much a helicopter evacuation costs to the climber or the patient?
Approximately $5,000.
Okay. All right. And I'm not sure that we covered this, but from a funding standpoint, you're all here as volunteers.
That's
Who
correct.
pays for the infrastructure or the equipment, the ultrasound, all that?
The ultrasound specifically is on loan from a company, as is some of the other equipment. We get a lot of funding from different embassies, the British and Australian embassies particularly. But the HRA is a not-for-profit organisation, so it's a charity that raises money, fundraising events all over the world. And then a lot of the medications donated from people that are up here, finish their trip, don't need it, and will leave it before they go down.
So one of the things that we see is that it looks like you have a lot of ability to improvise and work together. But where do you see Everest ER developing or advancing in the future? Where do you think it needs, and what do you think its goals are that may change in the future?
So that's a question, obviously, with a lot of different things to think about, to answer that. So the scenario of rescue in Nepal is changing, especially with the helicopters and then modern facilities, so recently people have been there have been a lot of few cases actually who have been evacuated from.
Improve the quality of the structures, which would mean that the environment we were working in was a little bit better. But we appreciate that it's wilderness medicine, and that's what wilderness is.
Yeah.
We just deal with whatever we've got.
Outside.
From a critical care intervention standpoint, there are a number of things you can do, but some things are probably very difficult to do up here. Walk us through how you would manage someone whose airway may be who needs to be secured up here. What resources do you have? Do you have things like ventilators? Can you move people like that in a helicopter?
So we have facilities to intubate people in if they were an extremist and really needed tubing, and we have a limited stock of drugs to facilitate that. Unfortunately, we don't have things like supraglottic airway devices. We only have tubes, and we don't have a ventilator. And I think that's one thing that, albeit would be very rarely used, hopefully very rarely used. If we did need it, it would be the type of patient where you would want a ventilator rather than to be handbagging someone for a prolonged period of time.
Hi.
Hi.
Looks like a busy day. Okay, I'm doing.
From an equipment standpoint.
Hold on, let me get myself out of the way.
We were talking about airway devices. It would definitely be useful to have some kind of portable basic ventilator should we need to ventilate anyone overnight. And some transfer equipment as well, because one problem we had with the major incident was that we had to send some of the patients down with the equipment that we had, and it hasn't come back, so we're now short of equipment. Another thing that would be quite useful, although it may not change your decision making, would be some kind of portable blood gas machine, just so that if we're treating people we can see what direction they're going. From a research point of view as well, we see a fascinating selection of patients up here, and if we're collecting this data for medical reasons, then we could also interpret it from a research point of view and learn more about altitude pathology.
Genius.
Great.
Obviously, deployment mountain medicine is very close to my heart, having done it and having been in faculty for it. Do you guys find that useful for your job here?
Yeah, very much. I think without the diploma training, like in mountain medicine, which I did, I don't think I'll be able to deal with the problems as better as I did, or as better as I do. So I think it has helped me a lot, like to do what I'm doing here.
You give that position pretty good.
Probably.
So guys, thanks for speaking to us. Is there anything else, anyone else you'd like to mention that's part of your team at Everest ER?
We are three of us, the doctors here, who do the primary thing of taking care of patients. But there is another team member. We actually are four of us. The another one is not a doctor, but he is our manager. He is our resource person. He is our communication manager. Everybody, everything. He's Lakpa Serpa. He is local here, and he knows everybody around the base camp. So he's really useful. He also does some long line rescues, and this is his 12th season in the Everest Base Camp. So thank you very much.
And obviously we couldn't survive without things like our cooks and our kitchen staff and people that bring us cups of tea in the morning and keep us warm. So that's really important. And even basic things like everything has to get here somehow, and we know that huge teams of porters carried everything up to start with and then flattened, because it's a glacier we're living on, so they had to literally flatten the whole site, chipping down ice, moving big rocks and things to make our tents flat. So it's a team effort, definitely.
I think not just wellness, this really is extreme medicine, which what this podcast is all about. Excellent. Thanks for tuning in, folks. I'm Yash.
Yeah, I'm young Trojanowski.
Thanks for signing in to Extreme Medicine.